Now, a person under investigation is someone who has acute respiratory illness with sudden onset of at least one of the following: either cough or sore throat, shortness of breath, or fever. Fever could be measured, which is objective, or history of fever. People say, look, I've had a fever. That should also be considered. So this is when you now decide to suspect at working in the facilities. When you deal with community tracing out there, they will look at two signs, two symptoms, not one. When people present to a healthcare facility, it is one. I think that was clarified yesterday, and we can also emphasize today about it. So persons at highest risk are those who have acute respiratory illness and who in the 14 days prior to the onset of symptoms met at least one of the following epidemiological criteria. Is either they are close contact. When you have this slide, you click to the notes, you will see definitions of all this clearly put there. But a close contact is someone who's been in contact with a confirmed person. Confirmed person means somebody whom the laboratory has, confirmed that they have SARS-CoV or COVID, or probable will be where people have symptoms, they present with a clinical presentation of SARS-CoV-2, but the laboratory is not confirming. That can still be called probable. But also history of travel is important. I think at the beginning, this was probably the one most important criteria, but at this point in time, it is changing, but people are still moving around. We mustn't make that mistake of thinking that everyone is locked down. Those who work in an environment where there have been cases reported, like we hear now and then, or those who are admitted with severe pneumonia of unknown etiology, these are people at highest risk, and we need to be taking samples and examine them. Now, as you manage this, when you start suspecting COVID or SARS-CoV-2 in a clinical environment, you use your N95 respirator. If you don't have, use a surgical mask. But we know that there's a difference between these two. Surgical mask in the context of airborne disease like tuberculosis or any other airborne disease are used by patients, people who are infected, so that they keep the bacillus to themselves. But your respirator does both. You would keep to yourself if you have any bacillus, but any particles of the size of between 1 to 10 microns will be blocked, will not go through the respirator. That's why it's called a respirator. N95. 95 means 95% filtration efficiency. This targets particles of those of a size between 1 to 10 microns. That's why you say 95% filtration efficiency, as we call N95. This is an American NIOSH thing. Europeans have FFP2, which is equivalent to N95. We're used to N95, but FFP2 is equivalent to N95. So this is what really healthcare workers need to do, protect themselves, separate patients. Don't keep patient whom you think could be having coronavirus, share the waiting area with other patients. They infect all your patients. You need to educate them on how to cover the nose, because that's the time when they are still able to listen to you. If you wait till the diagnosis is positive, people are depressed, you start educating them, is a waste of time. Uh, Hand hygiene is very important, but also think about early initiation of supportive therapy. It may be necessary in clinical environment. Now, in terms of laboratory diagnosis, once you suspect, is either a PCR test that is done. We know that after doing the PCR for for a couple of weeks, we receive some cartridges that are used for GeneXpert cartridges. So this is the machine that is traditionally used for tuberculosis diagnosis. There are more cartridges now for coronavirus. We know that there's also cartridges for HIV. So like I was saying, this is like a coffee machine that has that helps you make tea or milkshake or whatever drink you want to make. So the machine is a wonderful technology. The cartridges are very important. We come back to the samples later. But what I can say at this point in time is that the antibody tests that have a potential to be point of care are not yet in place. So we have to wait, because GeneXpert and PCR tests are done far away at labs that are far away is a bit of a problem. But when we get antibody tests, it will help a lot with decentralization of testing and all that. So these antibody tests are not yet validated. So we wait. Research is still going on. And when we hear something, we will let you know. Now, in terms of differential diagnosis, it's very interesting. I mean, you saw the symptoms there, cough, fever, all that. It's really overlaps with HIV, TB, PJP. I think this, you old people like us, we used to call it pneumocystis carinii. But it's changing. All these are changing, but it's still the same thing, same disease, same condition. So you may need to do chest X-rays and various other tests to make sure that you find out other things. It doesn't mean that everyone who's coughing at this point in time has only TB or only COVID or COVID and TB. They could have other infections and all that. So doing other tests is very, very important to exclude other conditions so that you treat your patients effectively.